Thank you very much. So we'll get straight in with the scene setting. So most people in Northern Ireland with dementia or mild cognitive impairment don't have a biomarker diagnosis. So dementia being when people can't do things they used to be able to do because of new and progressive problems with their memory and thinking that's not due to something else. And the reason a biomarker diagnosis might be appropriate is if you're trying to work out which disease process is causing that dementia or MCI. Now, for lots of people, that's not appropriate, and that's fair enough. We don't put people through investigations if there's no reason for it, and we don't pay for investigations if there's no reason for it. But for those people for whom it might be appropriate, I'm going to set the scene, or I'm going to discuss the lay of the land in Northern Ireland, give a brief outline of the lay of the land in Northern Ireland this evening. And particularly with reference to CSF analysis, which is what I have recent experience with. And also, by way of setting the scene, biomarkers for Alzheimer's disease. So there are a number of different diseases that cause dementia, Alzheimer's disease being the most common. The biomarkers for Alzheimer's disease can be thought of using the ATN criteria, so amyloid, which is detected using amyloid PET scans, which we don't have here, or CSF analysis. Phosphorylated tau, which is usually identified in the CSF and probably now in the plasma too. And neurodegeneration, which we detect using MRIs, FDG PET CTs, or total tau detected in your fluid of choice. And the reason that this is particularly pertinent at the moment, as we all know, is the coming of the disease-modifying drugs, which means that there is going to be a good reason for trying to identify accurately the disease process that is causing dementia and mild cognitive impairment for people. So a snapshot audit of 214 of my patients showed that 73 of them would have been potentially eligible for the disease-modifying drugs, and that was based on age greater than 50 and less than 90, MMSE or Addenbrook's cognitive examination scores being above a certain level and them not being on anticoagulants. And of them, 26 had had an MRI, and of those, 2 had had an LP and CSF analysis. So I run the service, and that's the numbers that I'm doing at the moment. So, and for a lot of people, that's appropriate. I'm not saying everybody should have a biomarker diagnosis, but for some people, they should. So the current situation in Northern Ireland, I thought, what a title. So luckily, I'm just going to talk about the current situation in Northern Ireland regarding the use of biomarkers to diagnose dementia-causing diseases, the advent of a dedicated CSF analysis service, blood-based biomarker research, just a few words on that, and even fewer words on current neuroimaging. And the reason you're hearing from me is that I'm an academic geriatrician working here in Belfast, along with my academic geriatric colleagues, and I work half my time in the Belfast Trust and half my time in Queen's University Belfast. And in the Belfast Trust, we run a geriatrician-led memory service and I have set up a lumbar puncture service. And from the Queen's side of things, I have experience working in research regarding CSF and plasma biomarkers, working with these people, sponsored by those people and funded by those people. And my experience started 12 years ago now when I did a PhD based in Musgrave Park Hospital, recruiting people who were undergoing elective hip and knee surgery and sampling CSF and plasma before surgery, along with doing cognitive tests. And then we recently followed those people up. I'll briefly mention some more about that at the end. So that's why I'm here. So currently, this time last year, there were 16,625 patients identified as having dementia using the GP register. So my GP colleagues tell me this is probably an underestimate because sometimes the way the dementia diagnosis is written down, so people might have a dementia diagnosis, but the way it's written down, it mightn't make it across to the appropriate codes to be counted. And as we know, obviously, too, a lot of people have cognitive impairment and dementia that hasn't been diagnosed. The interesting thing I thought about this was 6.7. The incidence, the raw incidence, or raw prevalence, was 6.7 people per 1,000, which when you think of the average GP list is 2,000 people, that's not a lot. Like, I think because we're seeing people with dementia week in, week out, I think everybody my husband always says, not all people have dementia. But, you think everybody has dementia, but being serious, so GPs aren't seeing as much dementia as we probably think, which I thought was a good reminder. But also, that is an underestimate. So based on the London School of Economics estimates of how many people in Northern Ireland probably have dementia, which is 22,000, our diagnosis rates are 62%, which compared to the rest of the UK is pretty good. England's 64%, Scotland's in the 50s, and Wales is 29%. So allowing for the fact that we're probably not catching some of the diagnoses that are already out there, we're not doing too bad, but obviously a lot more to go. These are the results of a study, a survey carried out with the Royal College of Psychiatry and AR UK, Alzheimer's Research UK in 2021, and they did an online survey and focus groups. And this figure shows the psychiatrist's perceived access to and confidence in interpreting different biomarkers. So you can see that overall they're pretty confident that they can access and interpret the structural imaging, CTs and MRIs, but much less so FDG PET-CT and much less so CSF. And indeed they commented in the results of the report that the respondents and participants from Northern Ireland, their level of confidence in access and interpretation was much lower than everybody else's. So, we have a lot of work to do, and we probably, we'll let that speak for itself, and we can talk about more about it at the end. So, setting up a dedicated lumbar puncture and CSF and fluid analysis service here, our local experience. And I thought, potentially speaking to people who might want to be setting up one of these services, because Gareth's going to talk to us about the lab analysis, and you could argue, and this is maybe for him to say, not me, that he could provide that service for the whole of Northern Ireland pretty easily. But I'm not doing LPs for the whole of Northern Ireland very easily, so everybody else is going to have to start doing these. Funding was the first thing. Whenever we set up, or we drafted a business case a few years ago, we were lucky in that Paul McGonigal, who's here present, and the neurologists have been doing this for a number of years. We're not starting this. Neurologists in Northern Ireland have been testing CSF for the markers of Alzheimer's disease for years, and they've been sending them to UCL and paying for that service. So we said, well, they very kindly gave us a cost and said, we'll get on board with this. So we said, well, if you save that money, can we have that money for the kits? And that's how we got the okay to go ahead. And then the cost of the nursing and the medical time was just kind of absorbed into the usual outpatient service. Nursing support, is, as in everything, is key. So, you need to figure out where you're going to do this. You need to know who's going to help. The training is really important. So we went to, because I had done my PhD in Musgrave and had watched over 300 spinals, I was, they knew me and I knew them. And so we went over, they had us and they had me and the nurses into theatres, and we watched the nurses practice getting the patients positioned, because it's such a vital thing. And obviously, which it's, anathema to the neurologist, but I don't care about doing pressure, so I'm happy to do everybody sitting up as opposed to in the left lateral position, which is much more difficult. So if you're doing them all sitting up, it's easier. And it really is key. The positioning is key. And the nurses in theatres, they're doing spinals day in, day out. They're really, really good at this. So I think that's a key thing. And then also the nurses will help you with the writing of the different risk assessments and all that kind of stuff you have to think about. And also admin support is key. So the service we do is not considered an appointment. So our secretary organises all of this. The referrals come to her. We'll talk about eligibility now in a second, but she writes out to the patients. She sends out the patient information letter and the different template letter that we choose. She deals with making sure that everybody who's had an LP that we get all the results and the forwarding of those. And all of that she deals with, so admin support again is key. And there are a number of documents that someone setting this up would have to write. Shameless plagiarism and borrowing. So Sean, as again, people have been doing this already. Sean Kennelly in Dublin, in Tala, they've been doing this for a number of years. So we borrowed with their full permission, their patient information sheet, and plagiarised the life out of it, and added a few bits, took bits away, and made our own. And I'm quite happy to share everything I have with anybody else who's interested in setting something like this up. And you have to write your SOPs and your risk assessments and all those different things. And then you have to get yourself ready to do all the LPs and make sure you're decent at it. I'm happy to chat to anybody about that if they like to. So what we are currently doing in the Belfast Trust, people refer, and I have started this off, but I'm delighted that Dr. Cap Patterson has come back from UCL and is doing this now too. So people are referred for an LP with either one of us, and the referral letters received, and we consider eligibility. And now I'll talk a bit about age in a minute, because these biomarkers, so we're looking for the accumulation of amyloid and tau when we're checking for these biomarkers in CSF. But that happens with age anyway. So above a certain age, you could argue there's no point in doing this because you're going to find these abnormalities and it's going to be more difficult to know if they're relevant or not. And the next slide we'll talk a bit more about that. In terms of medications, anybody who's on anticoagulants is out. This is completely elective. This is an entirely elective procedure, so I'm not taking anybody off anticoagulants for it. Antiplatelets are a bit different. So if someone's on Plavix, then clopidogrel, which is a very potent antiplatelet agent, then you do need to hold that. Now, for some people, you can just hold it and that's okay. For some people, you might want to bridge in with aspirin, and there are guidelines out there to help you deal with that. For some people, so I have a patient, for example, who had a heart attack in the last year and has stents in his coronary arteries and who's on 2 antiplatelet agents. So we will not be stopping those antiplatelet agents because you don't want his stent to clot, so he's just not going to get an LP. So those are the kinds of things you're thinking about if you're considering one. Blood test to make sure that their clotting agents are all in line. And neuroimaging. So most people will have had neuroimaging at some point, but I've had a couple of people who've had new headaches since their last neuroimaging, and then you'd want to make sure they don't have something else growing in their brain before you do an LP. So if they're ineligible, you write back to the person who referred them, and if they're eligible, you decide which of the standard letters they're going to get based on what you need to ask them to do with their medications. So as I said, age. So this is a slide taken from a study by Jack et al., which was a cross-sectional study of people who had normal cognition. So these were all people of varying ages, as you can see, who had normal cognition. So when we started off with this, I said 75 was so I've asked at different conferences with the great and the good doing all these, what's the age cutoff, and no one really wants to give you a number. So I was going with 75 initially, because if you can see, so these are people who had no amyloid and no markers of neurodegeneration, and between 75 to 79, only 43% of cognitively normal people have normal biomarkers. So if your chance of being abnormal is higher than your chance of being normal, then I think the test isn't appropriate. Now, obviously, then you have the issue of if their biomarkers are abnormal, if and when would that become relevant? Because you could argue that at some point for most people it will become relevant. But anyway, the point is, if cognitively normal people are more likely to be abnormal than normal, then I think that's the age range you definitely shouldn't be doing. But Kat, you would say, let you speak during the Q&A yourself, but you were saying maybe 70 it might be a more appropriate cutoff. So maybe we should only be doing these in people under 70. And Paul, again, you have experience of this, so that's something we can potentially discuss later. Other things to think about. There's a whole lot of ways in the way pre-analytical variables can affect the results you get. We could talk all day, but the thing to remember is amyloid's really, really sticky. So the A-beta 42 is really, really sticky and it sticks to everything. So what you don't want to do is what I did during my PhD and put a couple of mils of CSF in a big, massive 30 ml polystyrene container for it to stick to everything and then roll it around for a few hours before you process it. So that's the main thing you need to keep in your head when you're thinking about the pre-analytical variables. And for that reason, we should all be using these false bottom Starsted 2.5 ml tubes, because the main thing is what is the material of the tube you're collecting it in and what's the volume of the tube relative to the volume of CSF you're collecting. Because just remember, it's really, really, really sticky. And because abnormal amyloid is low, if you lower it abnormally, then what you're going to do, so if all the amyloid sticks to the side of the container and then your result is falsely low, and which is a false positive, that's something you really don't want to do. You don't want to give somebody a false positive result. So that's the rationale for being so considerate of your pre-analytical variables. So then to come on to some results that we've got. So these are the results, courtesy of Gareth, from our first set of analyses. So I thought it might be helpful. Where are we time-wise? Okay. Yeah, a few minutes just to mention a few cases. So yellow is abnormal. Okay. So you can see here so this first person was normal. You can see that their CSF, so their A-beta is 782, which is way above the 1030 cutoff. So it's way above there. It's way normal. That's fine. Their p-tau and their t-tau, so the upper limit the upper limit of normal is 27 and 300. So they're kind of getting there. So we're not, Paul and I have talked about this because, Paul, you've been sending yours to UCL for years. And when any of us use tests, you always get a feel for what's normal and what's not normal. So like B12, we all know that a B12 that's just above, it's just at the bottom end of the normal range. A B12 of 230, which is officially normal, but it's still a bit low. We'll probably all treat that just in case. So you get a sense of what's normal and what's not normal. And we haven't really, I think, is it Charlotte Tunison says you need 160 people to kind of get your head around your own normal range. So there are a number of these where the CSF, the TAUs have been kind of upper limit of normal, and I think we haven't really figured out where that, is that just, yes, that's still normal, we don't need to worry about it, or is that actually it's getting towards, because this man has some parietal atrophy, but is relatively cognitively stable, so it's hard to know what to think. You'll see that the PPAs are overrepresented here, and that's because we've been quite conservative thus far in why we've done LP, so is it really going to change anything? And people with a logopenic PPA, Alzheimer's disease could well be the process underlying that, and so I think it is worth doing an LP, and these people tend to be younger, so you can see why there's more logopenic, the incidence or prevalence of logopenic PPA in that table is much higher than real life, and that's why. So this lady's a lady, and she's 53, who has logopenic PPA, so her CSF amyloid is low, so that's abnormal, but her TAUs are normal. If our cutoff is 27 and 300, so they're kind of upper limit of normal. But she went over to London and had a positive amyloid PET and is in one of the trials, so she has Alzheimer's disease. So we think we are still trying to get our head around some of these. You can see that's a fairly clearly abnormal AD picture. The amyloid is low, the p-tau and the t-tau are high. It's fair enough. These are two quite young ADs and very clinically aggressive cases. And we have had a few discussions of, should we be looking for CJD and people like that. Again, getting our head around what this tau means. Are these the kind of taus you're going to see in CJD levels of high, or are they just AD? And that's way beyond my realm of experience, which is when I speak to my friendly neurologists. So yeah, I'm happy to chat about any more of those if anybody wants later. And so yes, then we whistle-stop tour through blood-based biomarkers and neuroimaging. So as I said, my PhD way back when, we collected blood and CSF. So we have work in preparation, manuscripts in preparation, looking at those results. And what I would say is that this study recruited people aged over 65 without a diagnosis of dementia who were getting hip and knee surgery. And their MMSE and cognitive scores would suggest they weren't all entirely cognitively normal, but they were a very well population. They were well enough to be getting elective surgery. And going on other people's normal ranges, there would be a lot more neurodegeneration evident in that group than we would have expected. So I think it all comes back to we are going to need to get our own normal ranges here and what's normal for us. And there will be, that's the website, there'll be more coming about that. And then the Northern Ireland Biobank. So the Northern Ireland Biobank was set up for cancer samples, and I'm probably going to misrepresent it here, but my understanding of it is it was to use clinical surplus. So you get a tumour cut out, you test it to see what it is, and instead of throwing it in the bin, you put it in the freezer and you research the life out of it, which is fair enough. The only thing you can take for the purposes of putting it in the biobank are blood. So at the minute we put our clinical surplus CSF in the biobank, and people attending our memory clinic are all invited to donate blood for the purposes of putting it in the biobank, which means it's there, it can be accessed for research purposes, and it probably represents a more representative group than normal research studies. We all know that research studies tend to be much more educated, much more well off than the normal population. I'm not saying this is perfect, but it's definitely a much more representative sample. And just to highlight how that works, because the NI Biobank is a bit different than the UK Biobank, which my understanding is all the data is there for you to just go get. But in the Northern Ireland Biobank, the samples are there, and if you want to research them, you have to get a clinical collaborator who looks after the patients, which is one of us, and then go ask for permission to work on the samples. And the Northern Ireland Biobank ask us for clinical data. They take it, clean it all up, anonymise it, and give it to the researcher. So that is an avenue for local blood-based biomarker research. And also the Nicholas study, led by our very own Professor McGuinness, is the Northern Ireland longitudinal study of ageing, which has been going for a number of years. It's coming into its third wave now, and its first wave, 15 years ago, we collected blood samples, which are there and are banked, and we have cognitive examination information from back then. We have questionnaire information since then. We're going to have another wave with another cognitive examination, so that's another avenue for local blood-based biomarker research. And then very, very brief 2 slides about neuroimaging. So I mentioned that it's a third of my potentially eligible patients had had an MRI. I thought this was an interesting observation of thirds based on that very small audit, which was about a third of the patients were potentially eligible. About a third of them had had an MRI. About a third of them would appear eligible. So there are a number of different contraindications to the disease-modifying drugs you'll find on MRI. So they can't have too much white matter disease, they can't have too many microhemorrhages. There's a list that I'm sure we'll all be familiar with this time next year. So about a third of the patients would have been eligible, about a third wouldn't, and about a third hadn't had sufficient reporting of their scan to be able to enable assessment of eligibility, given that I didn't feel fit to interpret the images. So I think that's something we need to talk to our radiology colleagues about, is that they're doing these scans, but just we can discuss perhaps how to make sure that they're reported in a way that we're able to interpret. And just one last mention, FDG PET-CT is not one of the biomarkers that we're going to use to assess eligibility for the drugs, but it is a biomarker that we have been very lucky to have good access to here in Northern Ireland, and we are used to handling it. John mentioned the MDM that we have every month, every quarter, where we talk about difficult cases, and this is a biomarker that's useful, and we have access to it here, and it is used here, and I think it's worth mentioning. So that really is the current situation in Northern Ireland, and we don't want to be too dramatic about it, but as John says, things are, with the advent of the drugs, things are going to change probably, and yeah. So with regard to biomarker augmented diagnosis of Alzheimer's disease, it is here. That's the current situation in Northern Ireland.